Right, so we're going to start our next session. And one of the biggest issue and what you really need if you want to have a care system is some sort of way of financing care. And of course, financing care happens in all sorts of ways. It can be through people's own time, providing care to, and support to others, which is a financing in kind, I'd say. It can also be through private systems and through public systems. And I don't want to say too much because I think Sarah Barber has a great introduction to the topic. So I'm very grateful to Sarah Barber for helping us organize this session and for her leadership in looking at what we can learn on financing care, thinking at the perspective as well of low and middle income countries. So Sarah, the floor is yours.
Thank you so much, Adelina. I'm really delighted to be here. Thank you for your kind introduction. I was really excited to hear about all of the country experiences, and what I'm going to do here is to talk a little bit about our research on long-term care financing with a focus on low and middle income countries, where in many cases no long-term care systems exist. So this research was done in cooperation with our colleagues in the regional offices, as well as the Departments of Health Financing and Aging. And long-term care has really received not so much attention in low and middle income countries. And I think some low and middle income countries fear that they cannot afford to invest in long-term care because economic growth is going to slow with population aging. But the needs for care still exist, and not investing in long-term care means that the costs of providing care shift to the family and to the health system. Relying on informal caregivers to provide long-term care means that they cannot work in many cases or drop out of the workforce. So ultimately, by not investing in long-term care, the negative economic impact of population aging is compounded. Because you're not only facing the pressure of older people leaving the workforce, you're also placing pressures on informal caregivers to, in some cases, leave the workforce to provide that care. We developed 10 briefs. I hope you can you guys see that okay? Sorry.
Yes, we see it well.
Okay. Sorry. Okay, so we developed 10 briefs that summarize the research findings. So I've listened to a lot of the excellent presentations, and I think I'm not going to talk about very specific countries examples, but just what we found in the research about how countries are addressing the challenges of building and financing LTC systems. So we developed a sort of triangle that illustrates some of the decisions that countries face, including, for example, which population they need to cover, the services that will be covered by public funding, and how these services will be delivered and paid for. The briefs are based on 6 supporting research projects, all of which are available freely on our website, covering, for example, gender, public financing, and workforce. I won't go into this in a lot of detail. The first one presents the evidence on the growing demand for long-term care, particularly in low and middle income countries, where we're seeing increasing numbers of older people, as well as an increasing share of people who experience age-related health problems before the age of 65 years. So if we see, for example, in countries that may not have invested in early life, they may experience the onset of age-related conditions in their 50s. And without formal long-term care, older people present in hospitals, which may not provide appropriate quality care for people with long-term care needs. It's also costly. So shifting people needing long-term care out of hospitals has been a really important driver of long-term care investments in many countries. In terms of population coverage, countries generally choose universal or selective approaches to coverage. Universal coverage approaches are based on the principle of equal access for health and social care needs, and selective approaches focus primarily on people in greatest need, as we were hearing, people with high levels of disability or the poor. There is a trend towards more countries taking universal approaches based on the principle of equal access. And we see in some low and middle income countries that they may start out with a selective approach, and then they build the systems for universal coverage. In settings where there is no public financing for long-term care, the costs are covered by family and the health systems. In high-income settings, countries identify the sources from general taxation, from grants, from insurance programs. Given that insurance is primarily funded from payroll contributions, this option is less feasible in countries where many people work outside of the formal labor force, similar to the health financing system. Different countries offer different benefits depending on the resources available, as well as the policies and institutions in place. And determining the scope of covered benefits requires establishing policies and systems, including inclusion criteria, assessments to determine social and health needs, eligibility thresholds. Priorities may focus on ADLs or activities in daily living, such as bathing, eating, or toileting, for example. And instrumental ADLs can also be prioritized where the objective is to keep people at home for as long as possible. Since long-term care systems evolve over time, systems are needed for conducting regular reviews of evidence, how well people are being covered in terms of the scope of the package, and how well they're being delivered through existing systems. Countries, we heard a little bit about countries trying to deliver services in different ways to ensure access and coverage, to balance financial protection, and to also promote financial sustainability. So many high-income countries are actually trying to shift services out of institutions, nursing facilities, to home. But as Adelina was mentioning, to do this, you do have to ensure minimum standards of quality. You have to deploy staff to the community or home. There has to be referral systems in place for medical and social care. And there's a need to establish monitoring systems for quality, which are much more difficult for community and home-based care. So contrary to sometimes the perception, this may not be the less expensive alternative, because we do have to invest in systems to make sure that the quality is in place. Most people cannot afford to pay for the long-term care services that they need out of pocket. So even in countries with a quote-unquote universal coverage, people do generally have to pay something out of pocket. This does tend to be based on income. So we see this huge variation in the generosity of the benefits packages across countries. The COVID-19 pandemic exposed very long-standing quality and safety problems in long-term care, and particularly in settings that did not have fundamental safety and quality standards or have measures in place for infection prevention and control. So we saw, for example, in these settings, very high rates of preventable mortality among older people. So this brought much needed renewed attention to the need for systems of quality assurance and data collection efforts for long-term care across all settings, both institutional and home settings. Particularly in low and middle income countries, there has been an emphasis on delaying the demand for long-term care by investing in health at earlier ages and including risk prevention and care for non-communicable diseases. This can include, for example, prevention and control of diabetes and hypertension, which left unmanaged may lead to disabilities in later life. In terms of generating sufficient resources for long-term care, some low and middle income countries are actually experiencing a youth bulge, which gives them time to strengthen their domestic taxation systems so that they can generate resources to invest in policies and institutions to manage and fund long-term care systems before large numbers of people need care. Countries have also invested in things like housing modifications and assisted technologies, which help people stay in their homes for as long as possible. Workers in the former LTC system face mentally and physically challenging work that is generally paid less than people with some similar skills. And in some cases, they may not have the training that they need to face the challenges that they face in intensive caregiving. So many countries see long-term care systems as a potential job creator, and they target recruitment to specific groups such as informal caregivers and students. So we do see that millions of women in particular provide care at home to children and older people, and they have, based on ILO studies, stated that they do wish to enter the formal workforce. So this is a potential a group of people who could be supported. Similar to other sectors, retaining long-term care workers requires fair pay and training opportunities for career advancements. Many countries, particularly high-income countries, for example, we're looking at Asia, Singapore, rely on migration, which can be beneficial both to the receiving and originating countries, but we do think that there needs to be some kind of mutual recognition of skills training for both countries. Assisted technologies may help caregivers in reducing their workload in some cases. Task substitution and continuing professional development are also strategies to support formal caregivers. Our last brief focuses on informal caregivers in low and middle income countries, where they replace formal care services where those services don't exist. So countries that have supported informal caregivers have provided formal services such as day services and meal services so that working age informal caregivers can keep their jobs and continue to work during the day. In addition, employers have offered leave benefits such as paid and unpaid leave. Many countries offer systems of cash benefits either to the caregivers or the care receivers, and there are a multitude of training programs for informal caregivers. But it is important to combine training with other policies and programs to ensure that they have maximum impact. That was a very brief summary of 10 detailed briefs. And I apologize, I didn't mention any specific countries, but if you do wish to read these 10 briefs or any of the 5 of the 6 background papers, they're all available on our website at wkc.wto.int. So please access those papers. Thank you very much.
Thank you very much, Sarah, and congratulations on an amazing body of work. And I'm now going to move to speakers from some of the countries that we may want to hear about their experiences. And first of all, we're going to go to Indonesia. And I understand that the Director of Poverty Alleviation, Tirta, has been called to answer an urgent question from the ministry, and that we have Dinar Karisma, who's going to speak on their behalf. So Dinar, if you can present now.
Okay, sorry. Yes. Thank you. I am very sorry because as many of you know that we just recently have our new president inaugurated. So we have new ministers, we have new structure. Yet the availability of our officials are very dynamic recently, and the minister just came to the office on Monday. That was Monday last week. That was his first day, and he's still keen in listening to the officials on what our ministry is doing. So. We truly apologize that our director, who has actually planned to attend, has been invited to join the meeting tonight with our deputy minister. So it is very unfortunate. As he would really like to actually meet you all, but hopefully next time there will be more opportunity. So thank you for the opportunity for Indonesia to present about what we have been doing in terms of providing care for the older people. It's been, I would say it's been a new initiative because we recently have the national strategy of older people of aging in 2021. So it is still new as well for us in developing what we would like to call as a care system for the older people in Indonesia. And hopefully we will be able to utilize the time that we have now to provide the best care for the current and the future of Indonesian elderly. So this is the situation now. Indonesia is still in the early stage of aging. We have about 24 million in 2045. This number is projected to reach 60 million. And currently, we under our regulation, people who are old are those who are 60 plus years old. About 10% of them, approximately, are in need of long-term care based on their ADL, IADL, and other measurement that we use. And about overwhelmingly 80 to 90% of those who are in need of family as a duty for their family to take care of the elderly. So unfortunately, this also shows that we currently don't have a system in place to provide a sufficient care for the older people in Indonesia, and we really still depend on the family members of the older persons. Yeah, so currently we have several regulations that are in place for many decades and focusing on the social systems of the older people. But since 2021, we have the National Strategy on Aging that is providing a framework for the Indonesian government to provide care and services to the older population in a more comprehensive way. So not only focusing on the social systems, but also providing equal rights, opportunity to still be active in politics, economics, and also protecting in terms of human rights. And this is what we use as well to support the government and mandate the government to develop a better long-term care. Currently, we have several programs that we can call as care program for the older people. The existing programs will consist of social services programs conducted by the Ministry of Social Affairs and the Family Planning and Population Agency, as well as the Ministry of Health. However, the programs are still scattered and the coverage is still very limited to those who are very poor and vulnerable. And currently, there are no specific programs provided for general population of the older people. Our ministry, the Ministry of National Development Planning, is now currently piloting what we call as the Integrated Older People Services. We piloted this in 5 villages into provinces that are aging fastest in Indonesia, Bali, and Yogyakarta. And we set this as an example of the community-based care provision program that hopefully will be an alternative for the community to provide some type of care services for the older people in the village level. And what we are trying to do is to replicate this. This year is the last year of the implementation, and hopefully in the following years we will be able to gradually replicate this to more than 80,000 of the community in Indonesia. What we do in this location is actually we try to identify community activists that have been working on older people care, such as social workers, cadres, and other community workers that have been very active in providing services for the older people care to provide coverage for the older people needs in the area. And we use a village as the unit of the services. And the group of the people usually consists of 5 to 15 people. They actively seek the information about the condition of older people in the village, in their community. So they know who are currently in good situation in terms of health, and then who are also in need of services from outside their family, such as from the Ministry of Social Affairs, from health services, or from the local government. And as far as they could, they have been trained by us. And as far as they could, they will provide the services, or they will try to link the older people in needs with the services that are currently provided by the government. And they also try to conduct several active aging activities in the community to provide a better community, more friendly community environment for the older people. And we see this as one of the cheaper way to provide care for the older people in the community level in Indonesia, especially since we don't have a system in place currently. We don't have insurance. We have very limited spending in terms of government spending for the older people programs. So this is one way to start having a program that covers more people, but also costs less expensive. The funding from the program is currently provided by ADB, but for the future application, we have tried to allocate budget from the central government, and we would like to hope that this will be matched as well by other funding sources, such as the local government, village government that have independent budget, also from the central government, and also other sources such as private sectors and community. We have been seeing from the pilots that we conducted in Yogyakarta and Bali that other than a budget that have been, other than financing that have been provided by ADB, these groups that we develop, this community level of older people care that we have developed, has been quite successful in collecting additional funding, such as they've been partnering with private sectors, they've been partnering with private health providers, they've been partnering with universities, they've been partnering with religious organizations to get additional funding and resources for them to be able to conduct more activities other than have been budgeted by the program under ADB. And this is what we would like to trigger, that they will be able to receive some type of funding from the central government. They will be able to secure some type of funding from the central government in the future, but they are also free to collect additional funding from other sources in order to provide better programs for the older population. So in the short term, this is what we think we would like to start with 10 of thousands villages in Indonesia that currently are in need of better care system for the older people. However, we are also aware that we need something that is more sustainable in the longer term. And once we reach 20% of older population in 2045, we probably will not be able to only rely on the community-based approach like this with limited funding. So that's why we also aim to start the long-term care insurance in the next 5 to 10 years. It has been mentioned also in the presidential regulation of the roadmap of social insurance that the development of the long-term care insurance is going to start anytime soon. And now the Ministry of Health and Ministry of Manpower are in charge in developing the study and the model for the long-term care insurance. So in the future, what we have is probably going to be a mixed sources of financing for older people care in Indonesia. Those who are financed by the government, especially for the more vulnerable and poor older population. We will probably still try to secure funding for the community level activity to enable aging in place for older people in Indonesia. And of course, we would like to develop something that is more sustainable in terms of financing through the long-term care insurance. I think that will be all from us. I hope this will give you some situation that we are facing now in Indonesia and what we are trying to do to overcome the challenges and hopefully to create a solution in a medium and longer term. Thank you.
Thank you so much, Dinar. It's really encouraging to see how you're building from these local experiences to then thinking about a longer-term national solution to financing. And sending you best wishes on these regards. We are now going to hear about experiences in Thailand, and I hope I pronounced the name well. We've got Myo Nyein Aung, who's currently based in Japan, who's going to talk to us about the effectiveness of a community-integrated intermediary care service model for Thai older adults. So the floor is yours. And I see you're already ready with the slides. Thank you.
Thank you very much. Yes, yes, and thank you for calling my name. Also, it's really great. It's a great honor to be here in the International Day of Care of Support, the Global Observatory of Long-Term Care. And my name is Myo, and I am an associate professor of global health, and I do the research in long-term care model and digital inclusion, and also I have a background in implementation research. So the today's topic is the community integrated intermediary care, CIIC, for the Thai older adults, which is the cluster randomized control trial conducted in Chiang Mai, northern Thailand. So this study, there is no conflict of interest, and the research multi-university researcher from Juntendo University, Japan, Chiang Mai Ratchaburi University, Chiang Mai University, and Chulalongkorn University, Thailand, and collaborated together with the Ministry of Public Health Thailand and also the hands from Japan International Cooperation Agency. And this research is supported with the funding by the WHO, the Center for Health Development, WHO Kobe Center. And first, I would like to start with this idea, and healthy aging is an investment. And many low and middle income countries, including Thailand, the long-term care is mainly the family base. And there is a balance of family caregiver burden, which is incurring the opportunity cost, and that can be sustained through the investment in healthy aging. And at the same time, other parts of the long-term care system, which is in high-income countries, or let's say the country with experienced long-term care system and insurance, such as the Japan and Republic of Korea. There are long-term care services. The cost is in terms of the professional care cost, and this can also, the cost can be balanced and reduced by the healthy aging. So if we look at the Thailand, the population aging is quite fast, and it's going to be like a current situation of Japan in 2040. It's very soon. And if you look at these pictures, and there is one son, and father is the left side of the hand has a problem, and mother has the right feet has a problem, and father is always confined to the bed in front of the television behind us. So such situations are very common. And at the time around year 2020, how much family are taking care of older person is the almost 98% of the care. Because this means that in terms of the facility-based care, Thailand is not well prepared at this moment. So this situation is very similar to many South Asian and also the low and middle income country. So who are paying this cost? And the family are bearing the cost in terms of the physical burden, not only in terms of the physical burden, and they have emotional burden, and they just occupy a lot of their time. They become socially isolated, and then some people lose the job. So such a situation challenges the sustainability of the care system in family-based setting. And the idea to develop the long-term care model in Thailand is how about increasing a little bit of the former long-term care and making the family to be stronger. So make it a little bit wider and make it a little bit stronger. So we're holding this idea, and also with the idea of prevention. So we created prevention-based new and innovative long-term care models. Because at the time of idealizing the study, there are a lot of bed-bound and home-bound people in the communities of Thailand. Thailand is at the time they have a universal health coverage. However, state needs to have a specific intervention to prevent the long-term care and to prevent escalating healthcare causes. So this is the intervention model. CIIC means that community integrated intermediary care model. It does not mean this is the nursing home or long-term care facility, and it is not the home. It is in the between. So then this will be ideally situated in the community setting, because we idealize that this can utilize the municipality funding of the district or sub-district level. And so we are convinced to the mayor to build the community integrated intermediary care center. And that center will have services such as screening and caregiver burden and dependency. Then we introduce the specific care prevention called the functional training in the form of group exercise and home exercise. That means to make the people active and keep their quality of the life. And then also technical training, because family caregiver have a different level of education and techniques are not sufficient. And at the same time, their needs are different. According to the Laura previous presentation, there are different needs for different people. So CIIC will provide the on-demand training, not the universal training, on-demand training for the at-home setting. And then when the caregivers are burnt out, we introduce community respite care. So at the time of this intervention, Thailand has universal health coverage, so that screening can bring the early diagnosis, and that will save the healthcare cost. At the same time, the Parliament has approved the aging fund, and that provide the assistant accessory such as a wheelchair and home modification. So combining all of these, we are thinking that this will be the affordable model. And I was convincing to the Ministry of Health, the more than 3,500 of the sub-district of Thailand, if they can use this, there will be a new system of long-term care. So here we can look at the intervention. Thailand is very familiar with exercise, but this exercise is not really aerobic exercise. We introduce a new kind of functional training specific for older person, which is safe and maintain their functional ability. Two is the CIIC nurse will go to the houses when they are in demand and train the care techniques and provide the respite home. So these are the intervention, how we make it. And this is quite interesting because prevention is very important, healthy aging. So the empowerment of the community with the techniques and equipment, we train the healthy aging exercise to the volunteers to lead the group exercise. And this is how we make it. And so the CIIC project includes older persons, their families, community stakeholder, municipality governments, and sub-primary healthcare, linking everyone. So when we have trained this, and the people have for self-efficacy and also the community empowerment to maintain their and control their life. So and luckily, not only the group exercise, we introduce home exercise because some of the people don't like to join the group exercise, and we make it for separate set for each day for 7 days. So it's really safe, our implementation, because we face the COVID-19 in the middle of the implementation. And this study effectiveness was evaluated by a cluster randomized control trial, which is a 6 cluster in intervention and 6 cluster in the control. And the control arm receive volunteer assistance and routine services. So this is the timeline. Although the net implementation is only 6 months, the trial preparation until the reporting stretched from 2018 to 2021. We also experienced the suspension of this trial due to the COVID-19. Then here we come with the results. And okay, let's say the baseline characteristic in 6 cluster in the intervention and control is not different. That means the randomization was successful. Then we look at the indicators such as the primary outcome is caregiver burden index. This is a unique point of the trial. I think it's very rare, and perhaps only one trial it used the caregiver burden index as the primary outcome. And then we can see that among those who received the CIIC intervention, 39.4% of the family could reduce their caregiver burden, whereas the routine care, 28.62%. The cost for this is only 294 Thai baht, and this is about $10 for 6 months. And the number needed to treat turned out to be 9.3. It is very convincing because the hypertension NNT is 12. So lower than 12, that means that this intervention is very compulsory. And then we can see that this intervention can prevent the functional decline, 83% in the intervention M, and compared to 78% in the control M. And respite care, with the respite care, the whole intervention will cost 669 Thai baht. But without the respite care, only 294 Thai baht per 6 months. And it is comparable to the cost of a diaper for a single person. So when we informed this to Ministry of Public Health in 2023, and they are preparing to scale it up. And here is come with our overview and the idea of the sustainability of the family-based long-term care system in many countries. Family caregiver burden can be reduced. So we can take off some of the load from the family by mobilizing the community resources and adding the formal care service of the long-term care, which is possible. And then also the healthy aging can be strengthened through the community-based social innovation for healthy aging. So we need to think about the involvement of the micro, meso, and macro level, and in the presence of age-friendly environment. And I think now today is more importantly also digital inclusion. So this is my conclusion. I hope that we have shown the effectiveness of this CIIC model to bring about the healthy aging community, and we hope that this will realize the universal access to health and social care for older persons in several countries who are experiencing population aging. Thank you very much.
Thank you very much. And I just want a fantastic example and also great to see such a robust evaluation of this intervention. I think it's really, really helpful to be able to make the case. I just wanted to mention for some reason, there are some two dark blocks that have appeared on the screen. So we'd be very grateful if we could share the slides afterwards as well, because we can't see clearly all of it. But fantastic overview and really encouraging to see also that the government is paying attention to this well-evidenced intervention. Thank you so much. We're now going to move to Africa. We're going to Southern Africa. We're going to hear from Professor Elena Moore from Juntendo University on long-term care financing in Southern Africa. Thank you so much for joining us, Elena. The floor is yours.
Okay, so good afternoon, everyone. I'm very excited for this talk, and I'm particularly in listening to the previous, speakers, both earlier today, but also just now in this session. My name's Elena Moore. I'm a professor here at the Sociology Department at the University of Cape Town, and I run the Family Caregiving of Older Persons in Southern Africa program. And thanks to Elena and the GOLTC team for the invitation, but also for hosting this webinar for this day-long event. This is very exciting. Just by way of background, just want to introduce our program. It comprises of 3 components working in the areas of aging, care economy, social protection, family relationships. And we're working very closely with government in 4 countries, as well as NPOs and different policymakers at local, national, international level, and particularly regional level, to try and really create more spaces for conversation, around long-term care. Obviously, one of our specific goals is to generate more evidence through our multi-country longitudinal research study that I'll introduce now. But, as it happens in these projects and programs, you actually spend a lot of time deep in policy work, probably more than you expected to. And so that's exciting to see. And we are, co-constructing policy options in South Africa, Botswana, Namibia, and Malawi. So just to explain, we are a team of about 40 researchers working in 19 different sites across the 4 countries I've just mentioned. We're working with about 340 families over time, over these last 2 years. And we're working together with about 60 NPOs, mainly local and regional, but also international. One of the key parts of our work is to think about the place of care and how that place shapes experiences of care. Now, we know we're here today, and I will share all of these slides. I know these probably details are difficult to see, they're difficult for me to see, but we're here today on International Day of Care and Support. And in reality, and I was interested to hear the first talk on unmet care needs, or just, the concept. In reality, we're still grappling in the region with measures of care receipt and care need of older persons in Southern Africa. Whilst care receipt is dominated by family care, which I will obviously go into more detail now, care need is deeply complicated in the context of poor access to basic services and limited community care. So whilst we can pull out figures about levels, difficulties with everyday activities, whether it's walking or dressing or eating or, all these activities, that only tells one part of the picture. And I think my earlier comments today really resonate here in thinking about how our environments are highly disabling for aging in place in this particular region. Now, as I mentioned, long-term care in the region is family care. We don't know what it really looks like, family care. We don't know the costs, the challenges, what makes it up, and that's why we're doing this work. So over the coming 4 years, actually, we'll be producing more reports and evidence about what it actually looks like. There is scant formal care services in the region, and interestingly, much that what exists are the remnants of colonial and apartheid era, specifically in Namibia and South Africa, of community health, of that care infrastructure that was built up throughout the 20s, 30s, 40s, and beyond. So, and it looked a particular way and had a very kind of a particularly British colonial manifestation. And you'll see how that kind of plays into the current era in a little bit. The other part of the care infrastructure is there is an extensive kind of community healthcare program that has been largely set up in response to the HIV/AIDS pandemic that is both government but also heavily donor funded, depending on the country and the region. So that's kind of what exists. What in reality, a key part of the context of long-term care is social protection, is the social protection system, which is set up. And we're looking obviously at 3 countries that could be characterized as high middle income countries. So at the latter stages or the higher stages of this idea of low to middle income countries. But we're also looking in Malawi, which would obviously be classified as a low income country. And in such upper middle income countries, they're very generous, I say generous with, generous and almost universal access to pensions. However, such pensions do occur in a context of severe gaps in other safety nets for other people in households and in communities where levels of multi-generational living are very high. And what that means is that pensions, albeit they are at the front of care and support for older persons, they're actually spread very thinly across many people. And there's kind of concerning debates in this regard, particularly in Namibia, about whether we should be investing in children rather than in older persons. And that's something that we will, pay some attention to going forward. I'm here obviously to talk about the funding of long-term care, but I have to show how levels of poverty, however we measure them, and I know the complications with measuring them in particular ways, but they're relatively high despite the presence of pensions and of social grants, mainly for the reasons that I've explained already. They are largely funded through taxation, but in Malawi, they are largely funded through a range of international donors. The list is long. There's over 10 different donors who are funding a program called the Social Cash Transfer Program, which isn't technically at a pension at all. It is a household level form of assistance. So if we think about what exists outside of pensions, we see that while South Africa has some residential care and community and health-based care programs and rebates for older persons, there's very little other forms of long-term care formal provision, either in Namibia, Botswana, and Malawi. There are other programs, largely food bank programs, or programs that are called the Destitute Persons Program in Botswana, for example, that do help older persons and older person households, not always specifically the person themselves. And I think this goes back to one of the points we were talking about earlier. I think a lot of what's on offer in the broader context of thinking around long-term care is often household targeted and household designed and not always specific to the individual. So today, however, I want to actually announce one thing. We have been focusing on the financing of elder care in the region. We're looking across the 4 countries, as I mentioned. But we also want to announce that we have recently received an IDRC CRDI award on transforming elder care that actually will allow us to continue our budget reviews that we have been doing and long-term care mapping and policy dialogues across the 4 countries for the next 3 or 4 years. So that is just something that we welcome, and we thank the IDRC for that funding. Now, to get to the heart of the matter, last year we published the first of a series of reports that is looking at funding elder care in South Africa, and this particular one was looking at South Africa. These reports are always complemented by the experience on the ground of such funding, whether that's formal provision or informal provision. And these reports are available on our website, and we can share them in the chat now a little bit later. But for us, our team, and for many NPOs, it was really unclear in the South African case what was happening over time and why the government and why NPOs were receiving less support, as the NPOs are largely the service provider of home-based care or other programs for older persons. So they're a key player in providing care, but their funding was being cut year on year, every year. So what we decided to do, and this wasn't part of our original plan, but we did decide to review the funding landscape in South Africa over the last essentially 20 years, since 2006, where the introduction of the Older Persons Act, came into play. And we looked specifically at the Department of Social Development, which has the statutory obligation of the state to deliver quality care and support services for older persons. Now, we obviously recognize the work that Department of Health and Housing and others do. But as I said, the Department of Social Development were the department that had that mandate and statutory obligation to provide and deliver quality care, where the principle of aging in place is the key policy direction in South Africa. Now, we found a lot of things, and I'm not going to go through everything, obviously, today, but what we found of interest, I think, in this session is that, first of all, we found that funding on community care, which happens in South Africa at a provincial level, was down 13% from the 2006 period up to 2022. So this is at a time where the numbers of older persons, as I think is common across the world, is rapidly increasing. South Africa has roughly 5.5 million older persons. And this was obviously a very worrying finding, although something that was experienced by service providers on a day-to-day basis, and it wasn't really new. The extent of that cut in funding was quite drastic. What we also found that was actually 98% of state funding goes towards pensions, which serves in South Africa 3.8 million older persons, approximately 75% of the older person population. It really only excludes the wealthy, and is not universal clearly, but is close to. What we also found was that only 6% of older persons receive this extra support, what's called a grant in aid. It's a small sum of money to be targeted to people and older persons in need of regular assistance. Now, our figure that, so basically 250,000 people were receiving this extra grant or extra support. And they were people living with high care needs, full-time care needs. And our figures would put this figure that it should be about 1.5 million people receiving that particular grant. So we have a current smaller kind of ethnographic study currently taking place to understand why there's such a low uptake of that particular grant. On the left-hand side of these kind of columns, you can see that there's approximately 80,000 people, older persons, receiving community-based care. That takes shape in either community service centres that run luncheon clubs, social clubs, some medical service, albeit limited, and more kind of recreational or cultural activities. But it also can be some home-based care services as well. There are roughly 18,000 people receiving residential care homes across roughly 400 state-subsidised care homes. Now, the worrying part of this, not only is it very low, but spending on care homes represents approximately 80% of the province's budget. So as I mentioned, community care, whether it's residential care homes or community service centres, is organised at a provincial level. And of the provinces that have residential care homes, 80% of their budget go to such. And that leaves very little money, or the pot is then obviously shrunk to what you can do in terms of home-based care or any other form of community-based care. So there's this huge gap, because residential care homes in South Africa, at least, are for the very, very poor and the very, very frail, and there's particular eligibility requirements that are very strict. And the service centres that I mentioned are for those who are fit enough to actually go to one, if there is one in their area. And you'll see shortly that there's many areas that have none. So these were the problems. So there's this huge missing gap of people aging in place, living at home with multiple chronic conditions, more than likely receiving no care or support from the state other than a pension. So we obviously argue that the state funding is not prioritizing community care despite its policy. Now, another important finding, and obviously this goes into too much detail here, is that what is important to look across the region and compare, higher middle-income countries to low middle-income or low-income countries. It's equally important to look across, particularly in places like we have a colonial history, to look at what's happening inside the country. An important finding revealed that highly uneven spread of resources across South Africa. So the post-apartheid spending was connected to an apartheid-era care infrastructure. So provinces that had the highest number of residential care homes were receiving more, And these are largely dominated by white older persons and provinces that had a higher proportion of white people living there back in the 50s, 60s, 70s, and 80s. That meant that areas such as KwaZulu-Natal, if any of you are familiar with, it's a very large province. It has about 1 million older persons, actually more currently. You know, there's basically 3,000 subsidized residential care beds in that province. So you can see the the unequal distribution of resources within the country, let alone now when we look at a regional level. So what we found, and as I said, we are continuing this work and looking at the funding models in the other countries. What we found is, needless to say, that unpaid family care dominates, and we're generating evidence on this cost. Who finances that at a private family level, and with what consequences, especially in the context of an increase in the number of older persons living with complex care needs, in levels of poverty, unemployment, multi-generation living, but ever increasingly in climate change-induced crises, particularly in Malawi and Namibia, but not only in those places. The poor limited, like LTC care infrastructure and financing, you know, can be seen. There's very little community health-based cares. In talking to our older persons and particularly the caregivers, you know, common across the world, caregivers are exhausted. There is no respite care whatsoever. There are few to no public policy supporting family caregivers. And so pensions in this context is clearly not enough. And it is really dominating kind of the thinking and the spending in government. And it's pushing a very strong familialist ideology. I'm very excited to hear from the examples in Thailand and Brazil that we've heard about today that, you know, give us hope that something else is possible. The problem, I think, what will arise in the coming years is it will obviously gain attention as the numbers of older persons increase. You know, currently in Malawi, there's 1 million older persons. But financing long-term care in the context in the region, it sits alongside huge concerns with food insecurity, drought relief, and other climate, you know, change-induced crises. And I suspect these forms of these other social crises will gain a lot more attention. I thank you all for listening, and I look forward to any questions. Thank you.
Thank you so much, Elena. And I promise you that next year, when we celebrate again the Day of Care and Sport, we will have more presentations from Africa, because I think today you're flying the flag for the whole continent. And we look forward to working with you to deepening the conversation and the understanding that we all have about aging in Africa and care and support. And thanks for all the amazing work you're doing. So now we have a bit of time for questions. The speakers have actually been very much on time, and this time we didn't come in as many, and we didn't have problems with slides. Feel free to raise your hand if you'd like to ask questions or pop them in the chat. And of course, the speakers feel free to ask questions of each other, because I can see a lot of potential for a dialogue between you as well. And perhaps I'm going to start with a reflection, which is that the figures that Elena showed on how so much of the cost of the spending that goes into formal care in South Africa is going into a very small number of people who live in nursing homes. And of course, that doesn't mean that these nursing homes are of great quality, I guess. And it just means that there's very little community-based care in infrastructure. And we have seen this historically also happen in Europe, where usually the first forms of support end up being some institutional care for people with no resources and no family and so on. And I see you raising your hand if you want to speak a bit more to that.
No, Adeline, perhaps I should just clarify that, you know, our work doesn't look at market-based care. So we don't look at any form of paid. First of all, amongst our family carers, no one actually pays caregivers to do that work. It doesn't exist. But we don't look at folks who, you know, pay market-related prices. And needless to say, people still have to pay a small sum to government subsidized state care. It's not as much as obviously private care, but just to say that we don't do that work. Yeah. It's also a tiny, tiny fraction of the population.
Thank you. And I was wondering, Sarah, if you want to come in and comment a bit on the previous presentations and some of you, some thinking that it's triggered by them.
Thank you very much. Yeah, I just to thank everybody for their terrific presentations. I've been learning so much. With Dr. Myo, I think it's a really important example of the value of evaluation, because there was so much effort put into a rigorous evaluation. And this gave the team evidence to present to the government so that the government could say, okay, this is what works. This is what works well. This is what doesn't work. So I think that that's a terrific example of the value of doing investing in evaluation so that we can learn from what we've done and to go back to our to government that spends a lot of money on long-term care to try to show what works. I had a question for Elena about the pensions issues and the extent to which we, to what extent, how much resources do go into long-term care from pensions? Because as you were mentioning before, the pensions themselves, particularly for multifamily households, are spent on quite a lot of necessities. So I would be interested to understand better the linkages between pensions and long-term care. That's a question right there.
Should I respond?
Yes.
So you're talking about, yeah. So Sarah, thanks for the question. So you're referring to specifically private households and what percentage, or not, how the state pension plays out in private households in relation to what goes towards care. And this, I think, goes back to earlier points around, pensioners, state pensioners, are spreading their pensions very thinly across many care needs, and that's how we need to understand also the place of long-term care in a wider context. And so in that regards, things like food is care, so a lot of older persons will say that obviously I can't afford multivitamin tablets, I can't afford any oils or creams or specific medication that I might need that are outside of the primary healthcare kind of support and products that I already receive, or devices. I can't afford a wheelchair, I can't afford crutches. But ultimately they'll still say, but I'm supporting my family and that's a priority. So it's balanced in terms of, there is a desire and a need to support others. So it's not that they're, and I should say actually in relation to that grant and aid, which is seen as someone, receives a grant who's in regular need of assistance, a lot of older persons actually see that as a caregiver grant, and they talk about it as a caregiver grant. So if I apply for this and if I get it, I'll give it to my daughter who's looking after me to recognize her work. So locally, that's what it's referred to often, although it's not how it's intended in policy. But yeah.
Thank you.
Last point, sorry, but we do have one report that looks at how that old age pension is spent inside the household, and I'll share that report with you now.
Thanks. And I was wondering, Sarah, if you want to comment a bit on Indonesia as well.
Yes, thank you so much, Dinar, for the terrific presentation on Indonesia. I think this is just phenomenal. Of course, it'll be very interesting to see how the Indonesian experiences scale up, particularly in countries. I mean, I think we see in Indonesia, I was attending a meeting one time between our Indonesian colleagues and our South Korean colleagues, and the Indonesian colleagues said, well, we don't have to worry about long-term care because it's being provided by the family. And our Korean colleagues said, yes, that's of course what we used to say too. Because you see the reality that you have smaller family sizes and you have the additional pressure, fewer family caregivers, and the additional pressure on the family. So I think it's really wonderful to see this scale up in Indonesia, and then it will be definitely something to follow in the future to see how this program scales up. So if you have any thoughts about what you view as some of the challenges in terms of expanding on this program, that would be very interesting. Thank you.
Yeah, thank you. I think the challenge is something that you just said earlier, yeah, that people still think that this is a mandatory this is a mandatory duty for the family to take care of the elder. So to have something that provides a replacement of that is something that is sound, ridiculous to some of our policymakers currently. And this is something that is only allowed to be provided if the family fails to function. And this is actually an issue because we see and we will expect that the number is expanding. For now, we have about 15 to 20% of older people are not being taken care of the family. A higher level of the socioeconomic status, they would replacement, and usually they also have better health status, health situation that allow them to live more independently. But those who are not, they are neglected. Basically, they are not supposed to live by themselves, but they do, and the condition is very bad. Indonesia has about 4 million of older people now, and we from our limited data set, so we are now gradually developing our data set for the older people. From our limited data set, about 1 to 2% are those who are in need of long-term care but no longer have anyone to provide the care to them, including their family. And the number is about 200 until 300,000 people. This is a lot in absolute. This is not much in terms of percentage of Indonesian population that is enormous, but in terms of number of people, this is huge. And this number can grow up if we don't do anything. In 2020, about 15 to 20 years from now, the number could go up to 1 to 2 million, and we don't want to see that. And this is something that we would like to prevent it from now. So what we try to do is actually to elevate the importance of this issue. We managed a couple years ago to create the to encourage the formulation of the presidential regulation of the national strategy of aging. And now we are trying to pursue another step to actually have a law on aging, which is couple step higher than the presidential regulation. Presidential regulation is usually political, depending on the president, but law is something that is more set up and fixated. And we have also mentioned this in our long-term development plan document that is also a law that was just ratified a couple of weeks ago, the importance of the development of the care economy in general. But we also mentioned the care economy for those who are in need of care, including children, people with disabilities, and older people. So we try to create the urgency by elevating the level of the document that we currently have on these issues, because that's what we do as a planning agency. But we also try to develop the pilot to create an example, so people will know that this is what it looked like when we are more prepared. This is what it looks like when community is able to provide care. This is what it looks like when the government can jump in to create an intervention that is providing a more age-friendly environment. So those are the things that we think will develop more political commitment. Do we actually have money to do that? I would say Indonesia is more than able to provide a budget for that, but it really depends on the political commitment. We have been for so long a young population that has been putting our attention more on the younger population, and this is time to change. And it's going to be hard, but we try to create and trigger that change.
Thank you. That was fascinating as well to hear the importance of having good tangible examples to be able to show what good looks like. And I understand also that the ADV pilots are being evaluated, I think, and I think that will also again help to build this evidence base that we need, isn't it? I'm going to ask a question to Myo Nyein Aung. So I was quite fascinated to hear that about the interest of the government. And I was wondering if you could say a little bit more about how community-based care is financed in Thailand more broadly, and also the relationship between the healthcare financing with quite an important investment already in community health, and how whether this is a case of expanding health care financing in the community to include this more long-term care type of care, or whether it's coming from a separate budget.
Thank you very much. I think Thailand situation is more reflected from the control groups in my cluster randomized control trial, and the community-based care in the existing services is through the volunteers. The volunteers are trained to be the certifying caregiver, but they are provided with the incentive to not the former kind of salary, and then the link between the primary healthcare centers and the families. So that was the currently the existing system of the Thailand. And after the COVID-19, actually we conducted this study during the COVID-19 and post-COVID. At the same time, we were able to have a plan and budget to extend this to the 6 areas of Thailand. So, however, during the COVID-19 pandemic, the priority substitutes to be the COVID-19. And after the COVID-19, now the current condition of the healthcare services, Thailand is trying to decentralize the primary healthcare center from the national budget into the provincial level. So they are actually the kind of model, what we propose in CIIC is very much ready to fit into that decentralized model, but we need to inform this more. And at the same time, another possibility of the inequality is now they more and more invest in the private sectors. It is really good to have involvement of the private sector. However, most of the population in Thailand are rural, and they are the farmers, and they are lack of the pensions and financial security. So then it can lead to some kind of the inequality, and I think it's very urgent to bring in the community-based and integrated models.
Thank you. And I see a question hand up from Katie Ko.
Yes, hi, this is Kati Ko, and I just had a question about the thinking about community-based models and wondering whether these could be, whether elder care could be overlaid on existing community health workers who, so in the case of Ghana, where I'm thinking about, there's a lot of community health workers who are oriented towards maternal and infant care, and and a lot of those little children are being taken care of by grandmothers, and so it feels like there could be an expansion of the community health model to include long-term care, which is not on the radar at all of the Ghanaian government, as for some of the reasons that have been talked about here, that it thinks of itself as having a youthful society. And I just wondered whether any of you, to what extent does it have to be focused, in the places that you were discussing? To what extent can this be an expansion of existing infrastructure, or does it feel as if it really ought to be focused on the needs of older adults? I hear Carla's points about the invisibility of older adults, and maybe that playing a role in creating political support for these programs. Anyway, I just wonder what your thoughts are on that. Thank you.
And anyone would like to start the answer? I see Elena's finger up. Yeah.
Easier.
Real hands up.
Should I go? I mean, I think, Kathy, you make a perfect point, like a great point. In South Africa, it's very interesting because you walk around any community and you'll see community health-based workers with a TB, HIV uniform on, and but they will be visiting older persons, and it is part now of their mandate, saying that they haven't received geriatric training at all. And they're funded, and their contracts are based on a TB HIV response. So it's not really integrated. It's happening in a very informal and potentially useful way, but there are big problems in that. In Malawi, there are calls for it. So some of them leading gerontologists or geriatricians who work in this area for many years have been asking for exactly that. They're saying this could be rolled out very easily. We have the people on the ground. It hasn't reached the policy level. It hasn't gone higher, but the ideas are there. And similarly, Botswana.
Thank you. And today we can have a Indonesian, Thai, or Sarah perspective from your overview. And also Carla, if you want to come in as well, Carla Giacomini, because I think the Brazil example is also very relevant to this.
I think the level of integration into health services, one of the critical questions is how we deliver long-term care services. And I think that we do, most countries do look at how they have delivered healthcare services and develop similar models in terms of how they're delivering long-term care services. But having said that, I think that, you do realize that, as Elena was saying, there is a different set of skills that you need for caring for older people. And so, of course, and we do find in general that if you have kind of highly skilled health workers, then this may not be an appropriate sort of extension for them, because it's a little bit more costly. But I think that, generally countries do look at how they have delivered healthcare services, and they try to identify the most effective ways to reach people, whether it's in their community, in their home, and institutions. But I think the level of integration is one of the critical questions that countries have to look at when they are considering how they deliver the best services for older people or people that need long-term care. Thank you.
Thank you. Any of the other speakers? If you want to, I just unmute.
Yeah. So I think this is very interesting, because what we call our pilot as the integrated older people care, which very emphasize on the integration of all care that are provided for the older people on the field, something that currently is not very optimal, but that's what I would call for the situation in Indonesia. And the integration is not only for healthcare, but the integration and connectivity between healthcare and other type of care, like social protection. The problem that is faced by older population is complex, and while it is mainly health, it also consists of older challenges as well. And as a planner, and I'm as someone that is not only working on the health sector, it is very hard to imagine that that care is only available in the health sector for the older population. Many of the challenges need to be solved by also other sectors. So what we want to do in Indonesia is to create a group that consists of those who are excel in different type of services. The group consisting of 5 to 15 people in the pilot area in Indonesia consists of social workers that are under the Ministry of Social Affairs, health cadres under the Ministry of Health, health workers under the Ministry of Health as well, and also other community workers under the family planning agency, and also religious groups, just to create a group that will be able to provide holistic and comprehensive intervention when it is needed by the older people, and also to identify holistically what they need when they are facing challenges. I think that would be all from our side.
Thank you. I just realized we're out of time. We could have had a bit more discussion on this, and sorry we don't hear about Thailand and Brazil, but feel free to follow up the conversation in the chat. I know it's not ideal, and I do think that there's potential here for an interest group on long-term care financing and developments on low and middle income countries. We have already a group in Southern Africa, but I think there's a lot of value in these exchanges across continents, and I think this session and the previous ones have shown that. So if you're interested, please let me know. I'll put my email in the box as well, because I do think we have a lot of potential to continue this discussion, and maybe with more depth and not in as much of a hurry.